Okay, dear colleagues, dear Felix, it is a honor for me to take a part and to give my presentation in this meeting of excellence in pediatric cardiology and congenital heart diseases and surgery for congenital. How small is too small? But is it a disadvantage to be small? I ask myself. For example, this is the egg of the draft quail. It's 10 times smaller than Nandu. But this is a colibri, and the egg of colibri cannot be seen in this picture. But all these creatures are big enough in their relative size to support the life. Our question is, what is too small to support the normal circulation, therefore the life from our point of view? And if we look at the apoplastic left heart, we can recognize immediately that it is not suitable for the normal circulation. But what should we do with this one? It is very small, but probably the right one is very big, and the function is not so good. Therefore, the relative and absolute size is very important in our decision. The next question is, what should be small? Ventricle valves, vessels, and is it only small but fine, or is it severe dysplastic, and how should we operate with this? Therefore, from our patients' populations, we do not talk about univentricular, we talk about biventricular, and of course they are divided in these well-known parts, but the question is, what is balanced, what is unbalanced, what is too small probably from our point of view? And different standards are used to recognize, to define what is small. For example, smaller as Z-score of -2 is hypoplastic. That also was suggested in this paper of Fokker et al. Smaller as -2 is hypoplastic, ventricular hypoplastic AV valve, but it was extremely interesting for me. Also, this disproportion was taken account for possibility to operate for biventricular correction, -5 and -7.5. No patients were turned down, even with severe hypoplasia. Therefore, what should we think? Probably the surgeons just should put their sutures on on the correct place, and we have no hypoplasia at all. If it's so, then this equilibrist just can close his eyes and he can think that, no, I'm sorry. And he can just believe that we have no hypoplasia, but it is not so. We should think about the rules, because if we would not make it, we can fall down as this well-known small girl. Therefore, we should measure, and it was very, very interesting for me to find that this meeting of the Mayo Clinic that was addressed to the Symposium on Persistent Common Arterial Canal took place in September 1956, and it is approximately 60 years ago. Therefore, probably September is a very good time to talk about the AV canal, and at least all 50 years. And here's well shown the cleft and the left side of the valve and of the ventricle and the documentary of this symposium. Therefore, we know we should measure. And we know what we are looking for: ventricle VSD, AV valve. I skip it a little. And we know how we can measure it with different methods, maybe better or worse applicable. But what we should not forget that we have a very small amount of patients, and we shouldn't forget the inter- and intra-observer variability, because it is always the point of view of some physician how he interprets this data. We have algorithms are miniaturized according to the small amount, and the methods are simplified because we have not so much measurements in each institution that can be used for the calculation. Therefore, this is a paper from 1968, and it was interesting for me just to look for this. We know all this inflow and outflow part are not equal in the AV channel, and the cavity of left ventricle is small. Therefore, the left ventricle and AVSD is small per definition. It is already small. And of course, we can measure in MRI, and all that under these third percentile is probably very, very small, but it's not really applicable in all infants and neonates to go for MRI, probably in very critical cases. Therefore, we can try to make it with echo. And it is already possible. Of course, these were the normal hearts, but the result, according to this formula, were that we have also the Z-score from -3 to +3, and this is 20 milliliters, 15 milliliters, and if we make a line here, then here is approximately the patient who should be operated with a body weight of about 5 kilograms and approximately 4 to 5 months of life. Therefore, it is one of the methods that probably can be applied and correlate also with MRI. But the question is if the measurements of ventricle are sufficient to understand this small part of the heart. For example, Lacour-Gaillet in 1997 presented this data, and M-mode was used for determination of the small ventricle borderline this part and hypoplastic lower than 0.33. But 3 of 12 at 25% were deaths related to small overestimated left ventricle. In this study, the long axis ratio was used for discrimination. 19 patients were with small ventricle, and 3 of them failed for ventricular repair, but it is interesting, cleft was partially closed in 9 patients, therefore 50%. We go from the beginning of the operating well for re-entry and reoperation because the cleft remains open. Therefore, the left ventricle is not sufficient to answer this question. We go to the next step, intercardiac, to the valves, and this is the oldest index was developed in 1996. We measure the small AV area and divide it through the larger AV area, and in the same paper, the ventricular cavity ratio, this is this kind of measurement, compare the volume and the cavity of the left and the right ventricle, and in this diagram, this is the amount of patients. We can see this blue circle are definitely the biventricular, and here are the univentricular. In between this gray zone, this is a difficult decision because here are the deaths and here are the problems. And if we looking for the outcome, then the percent of non-survivors who were accepted for biventricular repair was still too high. 15 years later, the modification of the index, we divided the small one through the total area, and from this diagram we can see that here in between are biventricular, here are too small, and this is a gray zone. Therefore, this is a direction of the hypoplasia and the small left ventricle. These two examples, this was the first one from my first year, and this is after the correction 2 years later, completely disproportionate. The small ventricle is not more small, is acceptable. It is a normal left ventricle with the mitral insufficiency because of the resting cleft. But if you look for the development of the prognosis, then it is much more better from 1996 to 2010. The percent of the patients who survived with small ventricle being accepted for the biventricular correction from 60 to 85. We can try to calculate together. It's very, very small ventricle on the left side. You can see it in all these echo samples. But if you measure in this small child, and we measure the modified index, and if we measure the relation between the left and right ventricle, we go for biventricular. And surprisingly, it works. It is a normal ventricle on this side. Therefore, it was not so small as we can think about. But if we go from the measurements of the diameters to the flow dynamics, then we can ask, this is the biggest dam in the world, this China 3 George Dam, is this gate big enough for this river? Or can this flow pattern tell us something about the gate? With other words, can this object pass through this opening? And some indexes were developed to answer this question. For example, left ventricular inflow index. This is a division of the flow through the diameter, and the answer was that this index was the best one in the prediction of survival and according to other further indices in this population. Therefore, they had not only one index for determination of the small side, but stepwise 2 indexes for better prognostic for better prognosis of this patient. And the last one index, this is the angle between the flow into the left and to the right ventricle. This is a very complicated study with cluster analysis for discrimination of the small one ventricle, and we can say that the patients who had the sharpest angle had also the unbalanced ventricle. Therefore, the sharper the angle is, the worse is the future of these patients. Just one more calculation. This is the unbalanced intermediate type AVSD, but take a look on the opening dynamic of the mitral valve. It is only the transverse plane. We have no longitudinal opening of the ventricle. And if we measure it, it is in the gray zone. All these indices talk for intermediate in this unbalancing situation. Therefore, we can accept it probably for biventricular correction, but the last word is according to the zone of opposition that should be closed to prevent the insufficiency. But we have here the zone of opposition as a completely opening of the mitral valve. Therefore, if the surgeon closes this valve, the left ventricle have no inflow part more. Here you can see this from the interpretive picture. The patient was corrected by Myung-Cho, and the cleft was remained completely open. Therefore, the result is very well, but we know from now the reoperation will come any time. I summarize in this table all indices there speaks for very small left side. From all indices on our papers, these numbers are, if we under this score, then it is much too small. This question probably can be answered. The question, what is not so small, is much more difficult to answer, and that is a part of Professor Del Nido, I think, for the next presentation. But in this fight between anatomy and physiology, we need both these answers. We can not only measure it, we should also understand the direction and distribution of the flow within the ventricle. And I conclude in my presentation, once again, if you think about the absolute and relative diameter, this is the Earth. It is a big and very wonderful planet, and it's very big compared to Pluto. But if we compare the Earth with Jupiter, it is a very small planet. And Jupiter itself, if you compare it with the Sun, it is only a small ball, and the Earth is very difficult to find on this picture. Next step into the infinity, this is the Sun, and this is Arcturus. It is a huge star we can see. No. This is Arcturus, and this is Betelgeuse, and this is Antares. Thank you very much for your attention.